The next speaker is known to all of us, and I think it's a very, very important subject, which is on various biomarkers. Dr. Darshan Jhalla is going to speak and touch on the subject in detail, and we'll have the questions and discussions in the last. May I request Dr. Darshan Jhalla to have his presentation? Dr. Darshan Jhalla, sir.
Thank you, Dr. Chopra and Dr. Mahapatra, for the invitation and the introduction. The importance of treating heart failure has been aptly emphasized in the previous 2-3 talks. So it is important we understand that heart failure should be diagnosed early and it should be diagnosed accurately, because then only the GDMT will work. If we do not diagnose a disease properly, then the question of implementing the proper therapy does not come. So this is where biomarkers come into play. So in heart failure, like any other disease, biomarkers are used for various things. And what is a biomarker? It is a measurable and a quantifiable biological parameter which can be used to assess health and physiology of patients in terms of disease risk and diagnosis. Alternatively, a biomarker may be any substance, structure or process that can be measured in the body or its products and influence or predict the incidence or outcome of disease. And biomarkers can also be used to judge the responses of treatment, like pharmacologic responses or device interventions when we are managing a disease. So biomarker is any biological substance which can be used to assess the presence of disease, the severity of disease, and how to modify the outcome of the disease. So what is a good biomarker? It should be specific to a particular disease. It should be easily quantifiable. It should be predictive. It means it should be relevant to the disease progression or treatment. It should be fast and simple analysis. It should be stable, because there will be a considerable amount of transportation and time delay between collection of the sample and processing at the laboratory. It should be non-invasive, simple things like blood, urine, etc. And it should be proven in the various studies that it is meeting with all the criteria. In heart failure, the biomarker has multiple roles to play. We can classify biomarkers in heart failure as different types. For example, antecedent biomarkers. So let's take stage A of heart failure, where there is no disease, but there is a likelihood of disease progression. So if you have a biomarker, for example, like NT-proBNP in hypertension. So if a hypertensive patient has NT-proBNP which is high, we may think that this patient is at a higher risk of developing heart failure in future. And that is why we might be tempted to take proper measures right at the beginning. So this is where an antecedent biomarker is used to predict future disease development. Screening biomarkers are used to quantify or to identify subclinical disease. Diagnostic biomarkers are used to confirm the presence or, importantly, even absence of disease, because if a biomarker is sufficiently specific, its presence may indicate disease and its absence may indicate absence of disease. Staging biomarkers are used to stage the severity of the disease so that appropriate measures can be done. And biomarkers can also be used to predict prognostication of the disease and the response to therapy. So these are among the various roles that a biomarker may play in heart failure. So these are some of the known and not so known biomarkers. For example, we all know NT-proBNP and BNP, but there are some of them which we forget, and that is troponins, creatinine, and etc., various other things. The newer things are ST2, MR-pro-ANP, pro-calcitonin, galectin, NGAL, and MR-pro-ADN. And there are some which are not yet fully quantified, which is the neprilysin and epilin, etc. Now, today's talk, I'm going to restrict myself to a few of them, because idea is that we will talk about biomarkers which are available to us for treatment, which we can use in our day-to-day practice. And I will try and not talk about things which are not available to us and which are partly theoretical. So I will spend a little bit more time in elucidating about biomarkers which are available and useful to us. So in diagnosis of heart failure, we all know that it is important that when patient comes with dyspnea, 30% of them may not have heart failure. And this is where the appropriate therapy matters. So in the emergency department, when a patient comes, it is important to identify the cause of dyspnea. And why? Because if you wrongly treat a non-heart failure with heart failure therapy, the mortality increases. It is in fact worse than not treating at all. So diagnosis, fairly accurate diagnosis and rapid diagnosis of heart failure or otherwise is important in the emergency department. And because the outcomes can be different. You treat respiratory origin dyspnea with heart failure therapy, and you'll get worse outcomes than not treating it at all. So this is where the uncertainty in the emergency department needs to be addressed. And this is where the standard typical biomarker about which we all know is BNP, that is the natriuretic peptide estimation. BNP, of course, is not very commonly done. NT-proBNP is done more frequently because the assays are cheaper and they are more reliable to do. However, in the study called the breathing not properly study, the accuracy of BNP was 90% when you took the BNP level at 100 picograms per ml. So it could detect presence of heart failure and it could rule out heart failure with a very significant accuracy of around 90%. However, like I said, I'm not going to talk about natriuretic peptides because that has been talked about frequently. And if we keep talking about it, there will be hours together, and the other biomarkers which we tend to forget or not use them will be left out. So though BNP is a very good, accurate biomarker, there are problems with BNP or NT-proBNP. First of all, age is a very important factor which influences the levels of natriuretic peptides. Secondly, presence or absence of renal failure. The NT-proBNP especially becomes quite inaccurate if you have significant renal dysfunction. Presence of arrhythmias like atrial fibrillation will alter the amount of BNP which is detected. And various other, for example, sex-related variations are also known to happen in this condition. So let's talk about some other biomarkers which are supplementing the accuracy of natriuretic peptides. So we have these various ones. The first one that comes to our mind is what is called suppression of tumorigenicity 2 factor, also known as ST2. Now, ST2 exists in 2 different forms. One is the ligand form, which is bound to cardiomyocytes. And the function of this ST2 is to get the interleukin 33, which is a protective molecule, getting attached to the cardiomyocyte. So when interleukin 33 gets attached via the ST2L to the cardiomyocyte, all beneficial things happen. Fibrosis is reduced, hypertrophy is reduced, preserved ventricular function, and improved survival. However, there is another form of ST2 which is called the soluble ST2. Now, this soluble ST2 is the one which creates all kinds of nonsense. So what the soluble ST2 does, it acts like a decoy receptor. So it takes away IL-33 from the myocyte into its own combination. And it does not allow the protective combination of IL-33 with the cardiomyocyte. So the protective actions of IL-33 are lost, and what the result is more fibrosis, more stiff ventricles, more hypertrophy, and reduced survival. So levels of ST2, soluble ST2, not the ST2L, can be used as we use HbA1c. So they predict the progression and presence of a disease, etc. And the ST2 concentrations have been linked to 1-year mortality, especially in acute heart failure. And ST2 is not affected by age, sex, BMI, etiology of HF, atrial fibrillation, or anemia. And in a cohort of 879 heart failure patients, ST2 did not show any correlation with renal function, which is a major problem with BNPs. ST2 levels predicted 6 months DS hospitalization more accurately than BNP. And when you add ST2 to NT-proBNP in acute heart failure, you get a better stratification of risk, as you can see from this, that those are the worst who have both elevated, and the best prognosis is where both are not elevated. However, even between them, ST2 levels were more predictive of progression as compared to only NT-proBNP levels. And addition of this led to reclassification from a moderate to severe disease. And this is the problem that we want to stop, readmissions. And so now we are coming to an area where we might be even thinking of serial ST2 during hospitalization. And even ST2 levels correlate with presence or absence of significant arrhythmias. So how does ST2 change our thinking in the clinic? When the ST2 levels are high, we may start thinking of LVADs, we may thinking of ARNIs, ivabradine, and various other. Our thinking towards those therapies will increase. And as a part of treatment, those who respond to treatment by lowering their ST2 levels by 50% have the best survival. And that is how we will be able to judge the response to therapy. And aldosterone blockade is known to reduce ST2 levels. And where to start aldosterone? Those with the highest ST2 levels respond best. So that is why ST2 estimation adds very good value to the presence to natriuretic peptides. And this is how my behavior changes based on ST2 levels. I improve the medications. I schedule visits earlier. I switch patients to RNA, and I start looking at patients in a more serious manner. Single ST2 cutout point, 35 nanograms per ml, increase risks. Second molecule that we don't tend to think is troponins in heart failure. Elevated cardiac troponins are observed in majority of patients, and the possible mechanisms of troponin elevation in absence of ischemia would be because of oxygen supply-demand mismatch and neurohormonal activation. So in acute HF, they are very effective prognostic stratifications. HS-TNI of more than 23 nanograms per liter was associated with an increased risk of hospitalization and death, and an increase of HS-TNT of more than 50% predicted a worse prognosis. So this is another hormone which can be used. PCT, which is not actually a heart failure hormone or a biomarker, but is a very important estimation. Heart failure and pneumonia are fairly common in ICU setups, and there can be almost 15 to 20% of patients who may have concomitant pneumonia, which may aggravate heart failure. So it is important to identify infections early. And this is where procalcitonin comes to our help. It's a protein biomarker of severe bacterial infection. It has low levels in normals, and it rapidly increases by order of magnitude in presence of systemic inflammatory response caused by bacteria. And it decreases proportionately when proper treatment is given. So 0.05 nanogram per ml is normal, 0.5 is significant infection, and anything about 2 is severe infection. And the likelihood and severity of bacterial infection is clearly predicted by the numbers of by the level of NT-PCT, and we can easily classify as where the level of sepsis is depending on the levels. And this has been proven in this particular study that procalcitonin aids in the diagnosis of pneumonia, particularly in cases of high diagnostic uncertainty. And a combination of natriuretic peptide and PCT can give you an idea whether this is heart failure with pneumonia, heart failure without pneumonia, or no heart failure and no pneumonia. So this is a good combination which can be used. Renal function markers are also very important in heart failure, and we all know the importance of creatinine, etc. However, creatinine is not very accurate, and this is where other markers like cystatin C come to our rescue, which elevates earlier than creatinine. And acute injury, renal injury biomarkers like NGAL, which is a very important and which is possible to estimate in our country, is also used to detect early AKIs. And elevated NGAL has poor prognosis, and a 167.5 level is associated with a 2.5 is more increased risk. Galactin-3 is another lectin which is produced by macrophages in a heart failure situation, where this galactin-3 is released by macrophages during a heart failure, and high levels of galactin-3 are predictive of significant progression of the disease. These are some of the futuristic biomarkers which we will not discuss because they are not available to us at the moment. And in future, a multi-marker biomarker strategy will be the order of the day. So in conclusion, although NT-proBNP and BNP remain the gold standards against which all other biomarkers are compared, novel biomarkers like ST2, HSTN, galactin-3 have made their way into American College of Cardiology and AHA guidelines. So a biomarker will make bad doctors worse and good doctors better. So there is no substitute to standard clinical history, examination, and other tests, but biomarkers will definitely help you. Thank you very much.
Thank you very much, Dr. Jhalla, I think, for a very outstanding presentation and your focus on 6 biomarkers due to paucity of time. And I think you brought something new, that there are a lot of caveats which we all should know, because most of us are using NT-proBNP or proBNP. Age is the important caveat. Renal failure, atrial fibrillation, and of course, sex you mentioned. They are very, very important and should be considered. Besides ST2, which you mentioned, is a very, very important, especially the soluble ST2 is more important than proponents and all.